Bismillah ar-Rahman ar-Rahim. Welcome fourth year EMP students. This is the first recorded lecture prepared and presented by me, Dr. Khalid Diab. I am an OB/GYN professor at Ain Shams University. Hope you find it useful and helpful. I will share with you the following slides that will review basic clinical management of abnormal uterine action and uterine dystocia and labor progress abnormality. By the end of this presentation, the student should clearly understand the following ILOs. The presentation will follow through the following heading titles: Overview, Normal Uterine Action and Labor Progress, followed by Abnormal Uterine Action and Labor Progress. Labor is defined as a process by which there is expulsion of product of conception after the age of fetal viability, clinically characterized by progressive cervical changes as a result of regular uterine contraction with increasing intensity and duration. The student is advised to revise the basic physiology related to the 4 stages of labor and its subdivided phases. Latent phase of first stage of labor is a period of time, not necessarily continuous, when there are painful uterine contraction and some cervical changes, including cervical effacement and dilatation up to 4 centimeters. Established first stage of labor is considered when there are regular painful uterine contraction and there is progressive cervical dilatation from 4 centimeters. The 3 main P's which affects labor progress are power, passenger, and passages. Furthermore, a clear understanding of the classic labor curve of Friedman showing sigmoid curve of cervical dilatation is essential to be clearly understood before hearing this presentation. Lastly, it is very important that the student should be able to know how to differentiate between false and true labor and between latent and first stage active of labor. Normal labor, also known as Dystocia, may be defined as spontaneous labor through the normal birth canal of a single mature living fetus presented by its vertex in the left occipito-anterior, unaided, uncomplicated, and within a reasonable time. That's to say, unduly prolonged or unduly shortened. Dystocia, on the other hand, derived from the Greek word meaning difficult labor, may be defined as any deviation from normality, as shown in the following table. The 3 basic P's which affects labor progress are shown. Dysfunctional labor represents a power default, which may be mainly primary or secondary as shown, and will result in prolonged labor or failure to progress. Other attributed causes of failure to progress are mechanical factors related to the power and passenger, that's to say feto-pelvic disproportion. Discrimination between both is important for management of later pregnancy. Note that dysfunctional labor is only diagnosed after exclusion of feto-pelvic disproportion. Furthermore, note that uterine dystocia may be subclassified into uterine underactivity or inertia and to uterine overactivity. As shown, primary power of labor is the true uterine contraction and, more important, uterine retraction, while secondary power is related to the abdominal muscles. The following figure shows a contraction cycle. Also, it's of utmost importance to differentiate between true labor pain, which is effective in inducing progressive cervical changes in the form of dilatation and effacement, compared to false uterine contraction, which may only lead to cervical ripening. In clinical practice, uterine activity refers to the force generated by the contraction of the uterine myometrium. It may be assessed by the simple observation of the mother pain level, or by palpation of the fundus by the service provider, or external tocodynamometry along with external fetal monitoring. Contraction force can also be measured by direct measurements of intrauterine pressure using intrauterine pressure catheter along with internal fetal monitoring. There is no specific criteria for adequate uterine activity. Generally, 3 to 5 contractions in a 10-minute period is considered adequate labor. This is a trace of external tocodynamometry. Details of monitoring has already been given in previous normal labor lecture. Verification of clear understanding of the pros and cons of each method may be discussed in the next face-to-face session. Classic intrapartum fetal monitoring include maternal, fetal, and labor progress assessment. Frequency of assessment is related to the stage of labor and other factors. All have been discussed in previous lectures. In this presentation, we will concentrate on normal and abnormal labor progress evaluation. Labor progress assessment is done by pelvic examination, measuring not only cervical dilatation and effacement, but also fetal descent, rotation, and increased flexion. Transabdominal ultrasonography and transperineal sonography has been used for assessment of fetal position and station, especially in obese women. The Friedman curve, as shown, and its norms established from Friedman data historically has been widely accepted as the standard for assessment of normal labor progression, already discussed in the normal labor. Philpott and Kessel in 1972 introduced the concept of alert line and action line, and the well-known partogram was used for clinical management of labor. New labor curves have been developed whereby some of the labor phases are expected to be longer compared to the Friedman labor curve. Discussion of the difference between the two labor curves and labor phases and duration is beyond the scope of the undergraduate student. The partogram is graphic representation of labor. Many partograms were developed. The most widely used is the WHO partogram. As regards components of the WHO partograph, it can be divided into 3 parts below the parturient identification data. The top part is related to fetal conditions, the middle part is related to the progress of labor, and the bottom part is related to the maternal condition. A modified WHO partograph differs from the original as it starts with active phase of labor due to marked variability of the latent phase. The following figure shows how the partogram is filled. The following figure shows how the partogram is interpreted. In the face-to-face session, verification that the student is able to understand the clinical use or importance of the partogram and how to fill in it complete data and how to interpret it. As stated before, normal true labor contraction may be differentiated from forced labor contraction being effective and coordinate. Abnormal uterine contractions or action may be either inefficient, ineffective being either subnormal inertia primary or secondary, or incoordinate uterine action, or being over-efficient, manifested as precipitate labor, which has its implication for the mother and the neonate and will be discussed by the end of this presentation. Over-efficient uterine contractions due to mechanical obstruction with faulty passages or passenger resulting from either true or relative fetopelvic disproportion, already discussed previously in malpresentation and malposition, will result in obstructed labor and, if untreated, will eventually result in neglected obstructed labor with either ruptured uterus or secondary inertia, according to the uterine response to obstruction, and this will be discussed at the end of this presentation. Also, there is a special forms of abnormal uterine action that will be discussed at the end, mainly uterine constriction ring and cervical dystocia. The behavior of nulliparous uterus differs from the multiparous uterus. This is critical in clinical management of cases. Nulliparous uterus usually respond to obstruction by inertia, while multiparous uterus respond by overactivity. Yet this may not be always the rule. Multiparous uterus may develop secondary inertia. Added to the well-known causes of uterine dysfunction, dehydration and oversedation, which should be corrected in all cases of uterine dystocia, there is a new evidence suggests that infection, inflammation, or vitamin D deficiency may play a role in uterine dysfunction. The following figure shows Toko recording of uterine contraction, which may be normal as in A, inertia as suspected in B or C, incoordinate as in D, while over-efficient uterine action may be tachysystole as shown in E, or hypersystole, prolonged contraction more than 2 minutes. If either is associated with fetal heart rate abnormality, uterine hyperstimulation is diagnosed. The following figures show uterine pacemakers and contractions. Label A shows normal uterine contraction pattern associated with a single dominant pacemaker focus, while label B shows a uterus with 3 separate pacemakers, all firing sequentially. Note that the uterine pressure achieved in this situation are less than those shown with a single dominant pacemaker. The Toko recording for this incoordinate uterine action is being seen below the picture.